This is the urinary system. It's chapter 28. The urinary system is one of your filtration systems, basically. And as you can see in this diagram here, we're going to be discussing the kidneys, which you obviously have two, the ureter, the bladder, and then the urethra. So you can see the positioning or orientation of these various organs. In terms of the urine that's going to be produced, that is all of the filtered waste products. There's a lot of physical characteristics associated with it. Typically in lab, you will discuss and test the urine for glucose and protein, and is there blood in there and stuff. There are certain physical characteristics that are associated with normal, healthy individuals versus someone who is unhealthy or has some abnormal thing going on or disease, etc., possibly infections. The physical characteristics will be influenced by several different factors, including water intake. If you are dehydrated and not taking in as much water, number one, the volume of your urine is going to decrease because the body is trying to conserve as much fluid as possible. Because there's less water being lost in the urine, the color of the urine is going to change. It'll be much darker. It'll be influenced by exercise, by environmental temperatures, by the food you're eating. There are certain foods, a lot of them don't influence the color, but there are some foods that will have an influence on the color of the urine. As I just said, this urinalysis testing provides a lot of valuable information about the overall renal refers to kidneys, so it's about the renal health, disease, etc. In terms of the normal, on average, volume production of urine is between 1 and 2 liters per day. The pH, there's quite a wide range here. It can be anywhere from 4.5 to 8. That's a pretty big range. We notice differences if you tend to eat a lot of meats, it tends to lower the pH. If you eat a lot of dairy products or a lot of vegetables or a lot of fruits, especially citrus fruits, that may raise the pH a bit. A healthy individual should have either very low or no protein in the urine and no leukocytes, no white blood cells in there. And there should be no blood in there either. And this table just is showing several of the different characteristics and what the normal values would be. And as I said, the urine color is influenced by several different things, the food you eat, etc. And this is just pointing out if you are well hydrated, then it's kind of this yellowish straw, pale yellow color. It gets much darker if you're dehydrated, and that's because the body, as I just said, is trying to keep as much fluid in as possible, which is the water. So that means everything else that's in the urine gets concentrated, including some of these pigments, and so it looks darker. If you're overhydrated, if you have too much fluid, it gets very, very pale, very, very light. In terms of the volume in different conditions associated with either too much or too little, normal, as I said, output is going to be between 1 and 2 liters per day. If you have what's known as polyurea, that's where you have more than 2.5 liters per day. That's quite a bit of urine. And that can be indicative of, there's 2 different types of diabetes. And it can be indicative if you have excess alcohol or caffeine intake. Both of those are diuretics, which will increase the urine output. It can be indicative of certain drugs such as diuretics. It can be indicative of kidney disease. If you have less than normal output, it can be either one of these 2 conditions depending on what the overall output is. It can be a sign of dehydration. It can be a sign of if you have severe diarrhea, you're losing water through the intestines, through the digestive tract, and so the way the body's trying to compensate for this is, once again, keep as much fluid in once again, it could be different types of kidney disease. In males, it can be an enlarged prostate that's having an interference. Severe decreased urine output certainly can be also indicative of kidney failure at this point. Look at the gross anatomy. We're going to kind of start backwards and move up. So the urethra is what transports the urine from the bladder to the outside of the body. Controlling the release of the urine as it passes through the urethra from the bladder is going to involve two sets of sphincters. There's an internal urinary sphincter, and yes, we usually say the word urinary in front of it because by now in your studies you realize there are several different sphincters throughout the body. You've got the pyloric sphincter from the small intestines, the stomach into the small intestines. And so just to clarify what we're talking about, you've got the internal urinary sphincter, it is involuntary, and then the external urinary sphincter, which is under voluntary control. In terms of the length of the urethra, in females, it's only about 4 centimeters. In males, it's much longer. It's about 20 centimeters, and it's divided into 4 different regions. Because it is much shorter in females, that leads to more, or at least an increased risk of urinary tract infections with females than in males, because there's much less distance, a shorter distance, only 4 centimeters versus 20 centimeters, for any type of microorganisms, especially like bacteria, to move from the external environment up the urethra and then into the bladder. Excuse me. And so just a small, shorter distance, quicker to get to the bladder, and in terms of any type of UTI, urinary tract infection, I mean, you've got the urine coming through, there's water, there's usually waste products, which for bacteria, they're like, whoa, this is food. It's warm, so it's a perfect environment for them to grow. So in the females, from the side view here, so here would be the uterus, and you can see that the bladder sits just under the uterus, kind of in front and under the uterus. Here's the pubic bone. So here's the urinary bladder, and the urethra is right here. So as you can see, it's a very short distance. Just want to point out, like I said, that where the bladder is relative to the uterus, and just to point out, this is why when a woman is pregnant, especially in the 3rd trimester, where this uterus has greatly expanded to hold the developing fetus, which is sitting on top of the bladder, exerting pressure on there, the bladder often cannot expand to its normal size because of the fetus. And then some fetus, when they're awake, they also like to squirm and move and kick poor mom on the bladder. So that's why, especially in the later trimester, women tend to often have to urinate more frequently. Let her take cuts in front of you in line for the bathroom, because that baby's pushing right down on the bladder. In males, here is the bladder here, but when you look at the urethra, as I said, it's divided into different regions or sections or areas, and so it wraps around here. So it comes from here, you've got these different areas. It's much longer than just this short little distance here. The bladder, it's a storage facility. It's where you're going to store the urine, so you don't have to run and go expel the urine every time you produce a little bit. You can produce it and store it in the bladder for a while. What's the capacity? Well, the bladder is made in such a way that it can stretch. It's that transitional epithelium which spreads out. And so in adults, it can hold between 500 and 600 milliliters. Now, you get the urge to have to release that before it's that full, but it is able to, to expand to that area. The trigonal area is a triangular area at the base of the bladder. It is formed by the openings of the urethra and then the 2 ureters. Technically, the term micturition is for urination or voiding. Incontinence, it's a loss of that voluntary control of the bladder. And that can occur for several different things, the reasons. sometimes infections, sometimes certain diseases, and sometimes with age as well. As you can see on this schematic drawing of the bladder, so here is the urethra, here is the external urethral sphincter and the internal urethral or urinary sphincter, you can use either term. So this is the bladder right here. This is the ureters, one from each kidney flowing in. So where do those flow in? Right back here. And then here is the opening to the urethra. So this triangle, that's the trigon area that we talk about. And then just from another viewpoint over here, once again, here is the bladder. Here are the sphincters here helping to control the release of the urine out of the bladder. And it is, the nerves are innervated, or the muscles are innervated by the nerves right here, the pudendal nerve that originates out of the sacrum area. And then when we move to the ureters, this is what's transporting the urine from the kidney down to the bladder. Obviously you have two of them because you have two kidneys. They are about 30 centimeters in length. You don't want them really tight because if they're real tight, you know, moving, stretching, there'd be issues. So as you can see, they will extend from the medial portion, that's called the hilum, this little concave area of the kidney, and then they will come down here, and once again here the opening is into the bladder. And now we're at the kidney. The kidney, they're retroperitoneal, so remember they're towards the back on either side of the spine. They are protected by muscles, fat, and your lower ribs. Yes, the right kidney is slightly lower than the left kidney. That's because of the liver. Liver is larger than what most people realize. You have to have room for it. If you did a dissection of the kidney, we do have videos of those for you to look at. Internally, there's two regions or areas. The outer area is known as the renal cortex, and the inner, deeper area is known as the medulla. By now, you should kind of be familiar with that, or at least be thinking when you see the terms cortex and medulla, in your mind, automatically be thinking, oh, medulla, middle, cortex, outer coat, if you will, on the outer. Within the kidney also, you have areas that are known as renal columns. These will divide the kidneys into different lobes. And between the columns, you have the renal pyramids. In a moment we see a picture, it's kind of triangular shape or kind of looks like pyramids. The renal papilla are areas, excuse me, they contain the collecting ducts, which are going to drain into the calyces. So when we look at a kidney, the renal hilum, that is this area right here. That is where everything that enters and exits from the kidney is that's the opening, if you will. So your blood vessels that are here, the nerves, the lymphatic vessels, as well as the ureter, which is going to come out and drain here. So you have the cortex, as I said, is the outermost area. The medulla is the inner area. So this is the cortex, this outer layer. These are the columns that extend down. And between the columns are the pyramids. So this is the renal pyramid here. Within this area, the cortex, beginning in the cortex, and as we'll see in a moment, some of the functional units of the kidney where you're producing the urine, some of them will extend down into the pyramid, but most of them are going to be in the cortex area. The papilla, as we just said right here, it's a bundle of collecting ducts. So the urine is going to be produced in the nephron. And we'll go over this in a little bit. But just keep in mind, the urine is going to be produced in the collecting ducts. And then those collecting ducts are all going to, throughout this entire pyramid and cortex, they're all going to combine here in this papilla area. So all the urine is going to collect here. Then at the very opening here, kind of this tannish color where it's smaller here, this is the minor calyx. So the urine is going to flow from the nephron into the papillae, into the minor calyx, now into the major calyx area. And then this larger, almost kind of funnel-shaped area, that is known as the renal pelvis. So the urine is going to go from the collecting duct to the papillae, to the minor calyx, to the major calyx, to the renal pelvis, and then flow out the ureter down to the bladder. That is the flow pattern, if you will, of the urine. You can also see here the blood vessels as they are coming in. So you have here your renal artery coming in. It's going to segment into what's known as your segmental arteries, kind of going around each little segment, which is why they're called that. You have your interlobal blood vessels around each of the lobes. Remember, the columns divide these into lobes. And then you have further branching, which is going to be the arcuate blood vessels. Then the smaller ones to the cortical blood vessels. And the veins are basically going in the reverse direction. You'd have your cortical veins, arcuate veins, to the interlobal veins, to the segmental veins, finally to the renal vein, which is then going to flow to the inferior vena cava. So as I just said, that renal ileum, that's the entry and exit for the everything coming in and out of the kidney. The renal pelvis is that funnel area, and it's going to collect all that urine that's produced by the kidney and drain it into the ureter, which then is going to drain to the bladder for storage. The renal blood flow, as I just said, the descending aorta, the renal artery branches off from that, enters into the kidney, and initially you have your segmental artery, and then the blood's going to flow where it branches further into the interlobal arteries, and then that's going to branch, forming the arcuate arteries, which then branches to form the cortical radiate arteries. Each of these branches, remember, with branching, the diameter gets smaller and smaller and smaller. So your cortical radiate arteries will finally branch into what's known as your afferent arterioles, which will then flow into the glomulars, which we're going to talk about in just a moment. That is where the filtration is going to occur, where you are going to be removing most of the substances from the blood, because the kidneys are a filter essentially. So it's going to, when you talk about filtration, you will be removing most of the substances out of the blood. Protein is too big, it will not move across. Most cells, like your leukocytes, are too big, they will not move. But things like your glucose, sodium, potassium, all those electrolytes, they will move. When it leaves the glomulars, it then goes to the efferent arteriole. Just FYI, this is one of the few places where you have an arteriole moving to the, basically a glomulus is a group of capillaries. From circulatory system, you know, normally as blood leaves capillary bed, it goes to a venule. In this case, it does not. It goes to another set of arterioles. So the afferent is bringing the blood to the glomulus, then the blood leaves, minus everything you took out of it, into the efferent arteriole. Then it's going to flow into the peritibular capillaries, which we'll see in a moment what's going to happen here. This is going to be wrapped around the whole nephron, which is that functional unit of the kidney. And now is where you're going to have reabsorption and secretion occurring, depending on what's occurring at this particular time in the body. You may be going, oh, we need to put some sodium back in the blood. Okay, reabsorb it back in. And where does that occur? You put it back in the blood through the peritibular capillaries. Oh, we need to take some more calcium out, or we need to put potassium in. And so this is where those processes occur along the peritibular capillaries. Then that blood's going to flow into a larger venule, which then goes to the cortical radiate veins, arcuate veins, interlobal veins, segmental veins, and finally leaves the kidney by the renal vein. And where does the renal vein drain into? Into the inferior vena cava, which we all know. Where is it going? Back up to the heart. Nice, clean blood. It's been filtered. So this diagram is showing here what we just talked about, what I previously showed you. So here's the renal artery, segmental, interlevel, artery. Here we go around. Now, this is what I was talking about, the, excuse me, the afferent arteriole is going to flow into, this is the glomerulus, that bunch of capillaries whose purpose is to filter out the blood. This whole complex right here, I know I haven't talked about it yet, but that is the nephron. That is the functional unit. This whole tan thing is the functional unit of the kidney. That is what is responsible for filtering, reabsorption, and secretion. Taking out, let's clean up the blood. This blood that's coming in has been all over. Who knows what's in it? Because who knows what you've been exposing yourself to? Who knows what you ate? And so we need to clean it up. That's the purpose of the kidney. One main purpose is for filtering. So the blood's going to come in here, in these capillaries. And that's where you're going to take most everything out of the blood, like I said, except for things like proteins. And it's going to go down this tan tube. And it's going to, it's like this winding road. But look, it's all wrapped with these capillaries. These are the peritoneal capillaries. So then as it's going through here, certain items are, okay, that's pretty good. We need more of that. It's cleaned up. It's fine. Let's put it back in. Okay, this is pretty good. Let's put that back in. Okay, that's pretty good. Oh, there's some things here we didn't take out of the blood right now. There's too much sodium. Let's remove it again. And so you're removing things, putting things back in, switching from this tan tube, which right here is the loop of Henle, switching back and forth with the blood. What is this liquid that you're forming here in this tan tube? That eventually becomes your urine. That's the waste products. And that process of reabsorption and secretion continues as you move up here. And then by the time you're down here, you're pretty much done, and what's coming out here is the urine. There's another spot where you can have a little bit more secretion occur if necessary. So this blood now, as it's going through these capillaries, you filtered everything out here, and now you're putting back in maybe the sodium, the potassium, chlorine, the calcium, depending on what is going on right now. If you just ate something that was really high sodium, you might be taking that sodium out of that blood, going, okay, we've got a little too much here. We need to take it out. Or maybe you've been really, really good and you were eating a really good low sodium diet. You might think, you know what, right now we need to get some of the sodium, put it back in, get it back in the blood. And so now what's going through the venule and then back, let's say through the whole network here and finally out and leaving the kidney via the renal vein, that blood has now all been filtered. Sometimes, one way maybe of looking at this, sometimes I describe it as you're moving through this nephron and you have these processes of filtration, reabsorption, and secretion. It's kind of like what's coming in here in the glomerulus. This is when, you know, you've been piling stuff in your garage for a long time and you just kind of keep stacking boxes on top of boxes, and you finally get to the point where you're like, I'm beyond just a normal spring cleaning. I really need to get stuff out of here. I have so much stuff. So what do? You move everything out of the garage. And then you kind of go through each box and you decide, is this something I want to keep? Is this something to throw away? Or is this maybe to, whether you give to Goodwill, whether you donate it to some other agency, or whether you put it up for a garage sale? You kind of end up with these different piles. And that helps you to visualize kind of what the kidney is doing. So as I said, that nephron, that is that functional unit. That's what I was just showing you. That glomerulus, that's that group of capillaries. There's a lot of pressure there to help assist with filtration. The capsule that surrounds the glomerulus, that is known as the Bowman's capsule, or sometimes you see it as a glomerular capsule. Blood's going to flow into that glomerulus by that afferent arteriole and drains by the efferent arteriole. So once again, here is that picture. So here's the capsule right here. Sometimes this complex of the glomerulus and the Bowman's capsule is known as the renal corpuscle. So in the renal cortex, you've got remember that outermost layer of the kidney. It's going to contain that renal corpuscle, the Bowman's capsule plus the glomerulus. It will contain the proximal convoluted tubule, which we abbreviate as PCT because biologists are lazy. We don't like to write out all kinds of words. And the distal convoluted tubule, or the DCT. It will contain the cortical nephrons. These majority of the nephrons are what we call cortical nephrons. They have a very short loop of Henle, and the entire nephron is contained within the cortex. The other type of nephron, of which is about only 15%, are the juxtamedullary nephrons. They have a very long loop of Henle, and so it does extend down into the medulla a bit. So what is the nephron doing? It's got to filter that blood. You want to get any toxins out of there. You also have to maintain homeostasis. How many times have you heard about homeostasis? That internal balance or equilibrium. The kidney is very much involved with this. Remember how everything is very closely regulated. The pH of the blood, the calcium levels in the blood. And most things are monitored in the blood. Potassium, chlorine, calcium, sodium. All of that's going to be monitored. And so what do you do if it's too high or too low? It will be the kidney that will make adjustments to maintain that homeostasis. If you're starting to get out of range, then it needs to do something to correct it. If sodium levels are too high, it needs to get rid of some of that sodium to bring the concentration levels down, and vice versa. And whose job is that to do it? That's the kidney. How is it going to do it? By filtration, reabsorption, and secretion. So different areas of the nephron have different main functions. Some of them can do all of this. Some of them have very specific functions. So filtration, excuse me, that is removing substances from the blood. That's the first step. It's where you're taking everything out of the garage. So you're going to remove the substances except for large proteins, cells. They're just too big to pass through. It's a size restriction. So you remove all that stuff from the blood. That's the first step. What are you going to do with that? Well, it's out of the blood now. That's the formation of urine. That's what you're doing, is you're forming the urine. Because one of the things that you also pull out is some water. Reabsorption is when you're putting substances from that urine that you just formed, that you just pulled everything out. That's where you're going, wait a minute, I really don't want to get rid of this. You know, when you're cleaning your garage and you put it right back in, that's what reabsorption is. It's putting stuff from that newly formed urine back into the blood. That is going to, where do you get it back into the blood? How do you get it there? That's where the peritibular capillaries come into play. They're going to be the capillaries that are receiving these things. And you're like, I'm not ready to part with this yet. Don't tell me I have to sell it, and don't tell me to throw it away, because that's not going to happen. I want it. So I'm putting it back in the garage. It's like, I want this. I need this. I'm putting it back in the blood. I'm putting it back through the peritibular capillaries. It's almost, if you want to think of it, you moved everything out of the garage door. I'm taking that box and I'm going in through the side door and hide it back in. Secretion. This is the final removal of substances from the blood. You've removed everything from the blood. You've put some stuff back into the blood that you thought you needed. Well, maybe now you get to the point, you know what? I really have not used this item for 5 years. So why am I going to have it taking up space? Let me just get rid of it. Yeah, I don't need it. I'll sell it. And with the money I make at a garage sale, I'll buy something new. It's kind of like, yeah, we thought we needed this. No, we're getting signals from elsewhere in the body. No, don't really need this much sodium. Get it out. So think of filtration and secretion are removing items from the blood. Reabsorption is putting it back into the blood. Infiltration occurs first before the other two. The capillaries of the glomerulus are very highly fenestrated. Remember, that means they have a lot of pores in them, and that makes it easier for substances to be filtered out of the blood. There is that size restriction. So as I said, large proteins, they're just too big to pass through. Cells, like your leukocytes, are just too big to pass through. Now, if you're doing a urinalysis test and you do find protein in the urine, sometimes you see that during pregnancies. But if someone is not pregnant and you see a lot of protein in, sometimes you get just a small amount. But if you see a lot of protein in the urine, your first thought is, maybe the glomerulus is not performing under normal situations. There's something going on there. That would be the first place I would start thinking of, because that should be preventing the proteins from passing into the urine. The filtered substances, they're collected in that Bowman's capsule, and they're going to drain into the proximal convoluted tubule. And this is where you start then the process as that fluid is moving through the rest of the nephron there. It's going to go through the proximal convoluted tubule, and that's where, number one, reabsorption is going to start, and then secretion. So this is the order it moves. So it goes to from the Bowman's capsule, it goes to the PCT, the proximal convoluted tubule. Then it's going to move to the loop of Henle. And then it's going to, from there, there's a descending loop. It's actually a loop, and then an ascending loop. It turns and comes back up. And then will go into the distal convoluted tubule. Through all of these sections, you have both the reabsorption and secretion. And once again, a lot of times is determined by what's happening right now, because the whole idea is to maintain homeostasis. So you can't necessarily, there are some areas where you know, okay, typically sodium's reabsorbed in this area. Is it actually going to happen? Well, it depends on how much sodium is in your blood right now. What's going on? Any remaining fluid after the distal convoluted tubule, any remaining fluid, that's your urine. That's what you have formed. It's going to flow into the collecting duct. Now, one collecting duct has several different areas that are connected basically to several nephrons. So it's receiving urine from several different nephrons. All that urine is then going to flow down, remember, to the papilla that I mentioned earlier, which goes to the minor calyx, the major calyx, the renal pelvis, and finally to the ureter. What are some symptoms of kidney failure? If the kidney's not working properly. Well, remember, the kidney it's filtering everything. It's helping to keep the toxins out. And so if it's not functioning properly, typically, and you don't necessarily have all of these symptoms, but some of your typical symptoms are going to be weakness, being lethargic, shortness of breath, widespread edema, that's swelling because you're not filtering like you should be, anemia, excessive urination, or sometimes the reverse, oliguria, where you have too little urine output. You may have metabolic acidosis. You could have the reverse, which is metabolic alkalosis. This is changing of the blood pH. You could lead to heart arrhythmia, irregular heart rates. You could have high urea in the blood, which is uremia. You could have loss of appetite. You could be tired. If your kidneys are starting to fail, it depends on the circumstances. If it's infection, treat the infection. Find out what the underlying cause is. Can you survive with just one kidney? Yes, you can. If you're in a situation with kidney failure, you can be put on dialysis, where You're hooked up to a machine and it will filter the blood for you. It's one of those deals. It is an alternative that we do have that we do not have when other organs start undergoing failure. Is it inconvenient? Yes, it is. Very inconvenient. Typically, when a person has to go on dialysis, they are usually hooked up to the dialysis machine typically about 4 to 5 hours. And usually it's 3 times a week. Every week. That is very, very tough on people. Some areas, I know my sister was telling me about years ago, some places are starting to look at, for some patients, and it depends on the patient's background, it depends on whether they've had training or not, but to try to ease the dialysis process, they're looking into if they can train the person or a caregiver to appropriately run the machine. If there's a way they can have the person have a dialysis machine at home, that they could be hooked up and go through dialysis at night. So it's less of an adverse effect on their quality of life. Some places have looked at that. I mean, you have to understand and recognize if there's something going wrong, what to do, how to correct, and have the responsibility of having one of those machines hooked up. So a few areas have kind of looked at that. Typically, they will look at the overall functioning of the kidneys, and for dialysis, it's usually when overall kidney function is down to about 17–18% that they will start dialysis. And depending on the situation, if they feel it's long-term, you may be put on a kidney transplant list. Excuse me. What can cause kidney failure? Several different things. It could be due to infection, cancer. I know someone that had issues with kidney failure and he was being treated for cancer, went through a very very large operation, and he did not have cancer associated with the kidneys or anything with the urinary system. It was just the surgery he had and the recovery, and then he ended up with a systemic infection, almost died from that. There was so much trauma to his body at that time that after the major surgery that he had, his kidneys shut down. And so he had to go on dialysis for a while. Now, in his situation, they were hoping it was not permanent damage, and they actually, over time, did start, as he recovered from the initial surgery and then the infections, and he was just being hit with one curveball left and right, and so he did survive. He had to be on dialysis for about 3 months. His kidney function returned enough that he was able to get off dialysis. Are his kidneys functioning 100%? No, but he doesn't have to be on dialysis anymore, which was a huge, huge thing for him. We were collecting movies and books for him to read, and movies. They had, I guess, a DVD player, so he could watch movies while he was going through dialysis. But it's a tough thing. Sometimes kidney failure can be a result of other issues. I actually have a sister who is in kidney failure. She needs to take medication for another medical condition that she has, and unfortunately, the medication to control the first medical condition, one of the potential side effects, and unfortunately it's a small percent, but she fell into that percent, causes kidney damage. So she is kind of in a situation of, I need to take this medicine for this other condition. If I take the medicine, it's solving the initial condition, but it's destroying my kidneys. If I don't take the medicine, I save my kidneys, But then my quality of life, because of the first medical condition, is horrible. And so she kind of had to balance what to do. And so she's taking the medicine. It is destroying her kidneys. She probably at one time was told that she may not be able to be placed on a kidney transplant list because of the fact that the condition, it's the medication, and she'd be continuing to take the medication. So if she got a new kidney, the medication is probably going to destroy that kidney as well. At this point, she's just kind of waiting to see her total kidney function. She has to be monitored pretty frequently. Right now, or at least the latest that I talked to her about it, her total kidney function for both kidneys total is about 22%. And she knows that if it drops to 17, 18%, that is when she has to go on dialysis. Now, she has been told that she would qualify for being part of this experimental group of having the dialysis machine at home and could potentially run it at home and undergo dialysis while she's sleeping at night. The reason for that, why she would qualify, is because she's not currently working, but she was a pediatrician, so she's a doctor, so she obviously would be able to know if, oh, this isn't developing into an emergency situation, how do I handle it, etc. One thing you often want to look at, what is the glomerular filtration rate? And this is something that her doctors, they will monitor this. It's the volume of filtrate formed by both kidneys per minute. Females, it's about 105 milliliters per minute. Males, it's more, it's about 125. It's going to be influenced by the hydrostatic pressure and what we call the osmotic pressure, the colloid osmotic pressure. Those pressure differences, as you can see here in the glomerulus. So here are your glomerular capillaries. And this is the Bowman's capsule here. So if you look at the pressure, you have a hydrostatic pressure of 55 right here, pushing outward. You have some hydrostatic pressure of 15 millimeters of mercury pushing in and 30 millimeters of pressure pushing in from the osmotic pressure. You add these two together, it's 45. So you got 45 millimeters of pressure pushing in, 55 pushing out, so it's a net outward pressure of 10. Things want to go from high to low. So if the pressure is pushing, there's more pressure pushing out. That's why, remember I said this is high pressure capillaries. That's why it's easy for filtration to occur. It doesn't require energy. It's just because of the difference in pressure, things are naturally going to go from this higher 55 pressure to the 45 pressure here. So it's a net gain of 10, so it's pushing it out. The higher pressure, think of it as pushing everything out. So all of those substances and some of the water being pushed out, and it's going to flow from here. This is the beginning of your proximal convoluted tubule. So you don't have to get bogged down on the pressures, but just know that it's osmotic pressure and hydrostatic pressure, and the two combined together is what's pushing. It's higher pressure in the capillaries pushing the substances out. Now, in terms of the reabsorption that occurs in those, the tubule portion, the proximal convoluted tubule, the lupohenley, and the distal convoluted tubule, for the reabsorption of that, so most of the fluid is filtered by the glomerulus. A lot of that fluid has to be reabsorbed. Why? Because remember, in the circulatory system, you want the volume of blood to remain pretty steady. You don't want drop and then increase. And to maintain that homeostasis, you need to maintain relatively level concentrations of all your electrolytes, and you need to maintain that volume of blood. So if you took a lot of water out, you need to put it back in. And you took a lot of those electrolytes out, but now you need to put back in to get it in within that homeostatic range, in that proper concentration, which means usually putting some back in, but then later do you have to, oh, we put a little too much in, we need to take some out again. So most of your reabsorption and secretion are going to occur due to concentration gradients. So filtration occurs because of pressure differences or pressure gradients. Reabsorption and secretion occur due to concentration gradients. Once again, concentration gradient, move from high concentration to low concentration. In terms of the water, are you going to reabsorb, put the water back in the blood, or are you going to have a net loss of water? That is going to be controlled by some of your hormones, such as your antidiuretic hormone, aldosterone, and indirectly by renin. And this diagram, I think, shows really well, number one, here is the Bowman's capsule. So this is the glomerulus in here. So you filtered everything out. Those substances are going to pass through the proximal convoluted tubule, which is here, down the loop of Henle, down that descending loop, made the turn. Now you're going up the ascending loop at the loop of Henle, and now you're moving into the distal convoluted tubule, and now finally into the collecting duct. So this is the collecting duct. And what are these little things sticking off here? Well, those are connected to other nephrons. So this is a nephron. Well, you have another one attached here, and another one here, and another one here, and another one here. That's when I was saying earlier that a collecting duct has several nephrons that are draining into it. And all this urine that's flowing in here from all these different nephrons, and you have millions of nephrons in each kidney, this collecting duct is going to come down. Well, there's going to be another collecting duct up here, and one up here, and one up here, and one behind it, and one in front of it, and those bundles form the papillae. And then that's going to drain to the minor calyx, to the major calyx, to the renal pelvis, and finally out the ureter. But this diagram is, besides just seeing, and remember all of this is wrapped with those peritibular capillaries, but sometimes it's nice just to see it without the capillaries so you can see, okay, how the flow of the urine is going. But this is also showing, excuse me, where things are being reabsorbed and secreted. So remember, reabsorption means you're taking it out of the urine, putting it back into the blood. So these arrows with it moving out, that's reabsorption. Where is it going? Back into the blood. So, and it lists here such things like your glucose, vitamins. Look at all these electrolytes. There are some additional things. If the arrow is pointing in towards the tubular, it's secretion. You're taking out, oh, there's some urea, there's some creatine, there's some other drugs, there's some hydrogen, there's some ammonia that were that was still in the blood that did not get out during the filtration. You know, it's not like the blood comes through here and, okay, let's sit here and stop for, let's stop now. Take a little coffee break and we're going to let all that stuff come out. The blood is constantly flowing through here. So not necessarily everything is able to filter out by the time the blood leaves. So this is a chance, excuse me, once again, those peritibular capillaries for additional items. Maybe the ammonia wasn't able to pass out through here. Not all of it got out. So now some of it's going to flow in from the blood into what's going to become the urine, and that is secretion. As you're moving down the loop of Henle, look, reabsorption of water, secretion of urea. Oh, reabsorption, sodium, calcium, chlorine. Now you're in the distal convoluted tubule. Reabsorption, sodium, chlorine. This is bicarbonate, water. Okay, maybe we put a little bit too much, over here, took in a little too much hydrogen, and so now, and once again, like here, put a little too much potassium, now we got to take some out. We got to get some more of that ammonia out. And finally, in the collecting ducts, there is a little bit more of water and urea that may exchange. So substances that are filtered and reabsorbed by the kidney in a 24-hour period, this is showing you how much is filtered, how much is reabsorbed. Well, if it's reabsorbed, it's put back into the blood. So how much of it remains in the urine? And do you excrete in the urine? Look at that. Most of the water gets reabsorbed. The protein, if protein got in there, it should be reabsorbed. Most of your chlorine, most of your sodium, most of your bicarbonate, that's going to play a role with the pH. Glucose. You ate that sugar donut. Let's not waste it, okay? Urea, you want to get rid of a lot of that. Potassium, uric acid, creatine, just to give you an idea. So what's regulating the blood flow through the kidney for all this filtration, reabsorption, secretion to occur in the formation of the urine, but the cleaning up, filtering of the blood? This is going to be controlled by a couple different things. In terms of the nervous system, the sympathetic nervous system, when it is activated, it triggers vasoconstriction. That is going to, once again, vasoconstriction reduces the diameter of the blood vessels, which means you're going to reduce the blood flow volume through the kidney. If you are reducing blood flow volume through the kidney, just so you know, part of that is going to result in the retention of sodium and water. If the parasympathetic nerve is activated, which normally it is, you tend to have vasodilation, so you have increased blood flow volume going through the kidneys, which is good because you want to filter as much as you can. There is something to keep in mind, what we call autoregulation, and that just means that despite any fluctuations in the blood pressure, the filtration rate does remain fairly steady. In terms of your endocrine regulation of the kidney function, there's several different hormones that can be involved. Your renin, angiotensin, aldosterone complex helps to regulate blood pressure. In general, overall, that's going to help promote sodium reabsorption. It's going to help with water retention and secretion of potassium. Your ADH, your antidiuretic hormone, tends to trigger reabsorption of water and decrease the urine volume because that's triggered during dehydration, and so you're wanting to conserve as much water as possible. You don't want to lose any. Endothelium and vasoconstrictors, natriuretic hormones. Natrium, remember, is the Latin word for sodium, so this is going to inhibit sodium and water reabsorption. And then the parathyroid hormone that blocks the reabsorption of phosphate, which in turn then results in an increase of calcium in the blood. Once again, you see the interaction between several different systems. In terms of regulating the blood volume and the composition of what's in the blood, first off, baroreceptors that are found in the aorta and the carotid sinuses, they monitor blood pressure, which in turn is going to be related to blood volume. When the blood pressure increases, you tend to have vasodilation and you tend to increase water secretion in urine. You want to get that blood pressure back down. When blood pressure decreases, you have the reverse, vasoconstriction, and you want to increase water volume and sodium. Get that blood pressure back up. Diuretics are any compound that increase urine volume. So things like coffee, tea, alcohol, they tend to inhibit ADH, which is the antidiuretic hormone, and so you tend to have increased urine output. That's why if you drink a lot of coffee, if you drink a lot of tea, or if you have consumed a lot of alcohol, that's why you have to pee a lot. There are a lot of regulations controlling the composition or the concentration of sodium, potassium, chlorine, and calcium. Remember, it all goes back to homeostasis. Okay. Kidneys play a huge role in the acid-base balance. We have another chapter focused just on that, but it has to do with maintaining the blood pH. It has to be maintained in a very narrow range. pH is 7.35 to 7.45. If you go below that, you're in trouble. If you go above that, you're in trouble. The lungs, the acid-base balance is controlled or regulated by both the respiratory system and the urinary system. The lungs can get rid of acid very quickly and help bring the pH up, so it can be a very quick response. Kidneys can also help get rid of excess acid or base, but it's going to take longer. It's not as fast as the lungs. It has to do with regulating the amount of hydrogen ions, bicarbonate, which is part of a buffering system. So this will be discussed in the acid-base balance. And it's regulating the pH of the blood. Regulation of some of the fluid compositions. Breakdown of proteins tends to result in nitrogenous waste products, mostly urea, a little bit of ammonia. Water-soluble drugs can be excreted in the urine. Larger drug molecules, or those that may be bound to proteins, are not going to be able to be excreted as well because they can't get filtered through that glomulus because it's a size restriction. Some of the other factors involved with homeostasis and the influence of the urinary system. Vitamin D activation occurs in the kidneys. Remember, vitamin D is necessary for calcium uptake. Erythropoiesis, that production of red blood cells, is often stimulated mostly by the kidney. Blood pressure regulation, as we just said. Osmolarity, which refers to solute imbalances, can cause water imbalances. And the end result is you can either end up with cells lysing, basically bursting, or edema, which is swelling. It's going to be involved with the recovery of the electrolytes. The three most common ones are going to be your calcium, sodium, potassium, and then, as we said earlier as well, the pH regulation. So the urinary system, yes, it's involved with filtration, removing toxins from the blood, removing drugs from the blood, etc. But it's very important in helping to also, as everything ultimately plays a role with maintaining homeostasis, maintaining that balance. Proper concentration, most things are monitored in the blood, so if the kidneys are filtering it, that's where they can make the adjustments. I got a little too much of this, not enough of that. Let's kind of shift things around a little bit. And like I said, they're a huge player in helping with that acid-base balance, maintaining the proper pH of the blood. Years ago, I can remember when I was working in New Mexico, I was in the faculty lounge working on something, and another A&P instructor walked in and was kind of frustrated and was like, oh, I have to go substitute for somebody's class. They're covering the urinary system. And he's like, oh, I just need a basic summary of how the urinary system works. And kind of quickly, without thinking much, I just kind of responded with, I said, the water goes in and the pee comes out. And he just stopped. Everybody started laughing, and he looks at me and said, you asked for a basic summary. That's the urinary system. Water, toxins, everything comes in, filter it, and the pee comes out. You're getting rid of the waste. Which is, I said, they all kind of laughed and went, well, we're not sure it's quite that basic. And no, obviously it's not. And my point in telling that is, yes, it's filtering the blood. It's forming the urine to get rid of some of those waste products. But as you'll see in another chapter, as I was just stating, it plays a huge role in maintaining the pH, that acid-base balance as well. So that is it for the urinary system.